pericardial effusions and cardiac tamponade. Please like and subscribe to the channel. Pericardial effusions relates to the accumulation of excess fluid in the pericardial sac. As this fluid accumulates, it can cause compression of the cardiac chambers, leading to impaired cardiac output and thus obstructive shock in the form of tamponade. The incidence of pericardial effusions is approximately 6% of the population and increases with age. The normal pericardial fluid volume is 50 mL. The etiology of pericardial effusions is broad. It can be acquired or congenital. Congenital cases are very rare and account for 1 in 10,000 cases on autopsy. Acquired cases can be infectious and non-infectious. Infectious causes include viral, bacterial, TB and fungal. Non-infectious causes could be idiopathic, injury, malignancy, uremia, Dressler syndrome, metabolic causes and irradiation. The classification of pericardial effusions is broad and relates to the onset, spread, size, composition and physiological effects. So the onset, is it acute, subacute or chronic? The spread of the fluid, is it loculated or is it global? The size of the volume and also the composition of the fluid, is it serous fluid, is it blood, is it gas? And finally the physiological effects, is the presence of tamponade, cardiovascular compromise. The pericardium is the fibrous sac that surrounds the heart. It has 3 layers, the fibrous pericardium, the parietal pericardium and the visceral pericardium. The parietal and visceral pericardia form the serous pericardium. The visceral pericardium, also known as the epicardium, is attached directly to the heart. The pericardial cavity, which contains the pericardial fluid, is located between the parietal and visceral pericardia. And the heart is composed of the myocardium, the muscular layer, and the endocardium. The pericardial cavity volume is relatively fixed, and therefore increases in fluid can result in significant increases in pressure. However, this is based on the speed of onset and the composition of the fluid. First of all, it's important to remember that the right side of the heart is a lower pressure system than the left side, and therefore these physiological effects will happen sooner on the right side than the left. So, you get right atrial compression extrinsically onto the right atrium, and this causes an increase in right atrial intra-atrial pressure and thus a reduction in pressure gradient to enable atrial filling. So you get a reduced venous return back to the right side of the heart, reduced right atrial volume and therefore reduced right ventricular volume, reduced ventricular output, secondary to a reduction in the Frank-Starling curve. As the pericardial pressure increases, these effects will also be seen on the left side of the heart, but it's important remembering that if the right ventricular output is reduced, the blood returning to the left side of the heart will also be reduced. But overall, as the pressure increases, you get a reduction in venous return, reduced cardiac output. This can lead to obstructive shock, leading to reduced coronary perfusion, and the patient is at risk of cardiac arrest. The pericardium, as discussed, is a relatively stiff sac, and therefore fluid within the pericardial space exhibits a pressure-volume relationship. Consequently, the compliance curve of the pericardial sac follows 2 patterns. Firstly, slow accumulation of fluid results in a slow rise in pressure due to stretch of the pericardial sac. Conversely, a rapid rise in fluid accumulation results in a rapid rise in pericardial pressure. The compliance of the pericardial sac can be affected by disease, i.e. pericardial mesothelioma or scarring. Importantly, also, fluid composition, for example blood, readily clots within the pericardial sac, which results in a more rapid transmission of pressure change. There's a range of compensatory mechanisms to maintain physiology. Cardiac output is maintained and thus flow to organs is achieved by increasing systemic vascular resistance, increasing the heart rate, increasing the force of contractility of the heart. This is achieved by multiple mechanisms. Important mechanisms include activation of the adrenal gland to release catecholamines and activation of the renin-angiotensin-aldosterone system to release ADH, aldosterone and increase sympathetic activity via angiotensin II. Clinical features are broad and are based on the underlying disease pathology and the speed of onset of fluid accumulation. Classic symptoms include shortness of breath, orthopnea and chest pain. However, there's a range of signs including quiet heart sounds, pulsus paradoxus and an increase in JVP. Beck's triad classically is associated with hypotension, elevated JVP, and muffled heart sounds. A range of investigations may provide additional evidence of pericardial effusion or tamponade. Bedside investigations include an ECG. This may show features of tachycardia or worse bradycardia, electrical alternatons, and low voltage QRS complexes. An arterial line may show features of pulsus paradoxus. Imaging: a chest X-ray may show an enlarged cardiac silhouette. An echo may have characteristic features of IVC dilatation, evidence of a pericardial effusion, and diastolic collapse of the right atrium or ventricle. The management of a pericardial effusion can be medical or surgical. Medically, you can perform a pericardiocentesis, or surgically, you can perform an open procedure by a sternotomy or a video-assisted procedure. It's important to remember for anaesthesia, these are high-risk cases, especially for patients with tamponade, and therefore the patient should be induced within the operating room with the surgeon scrubbed and draped. The patient should have a large cannula, an arterial line, and defib pads attached, and if there's time, central line. Vasopressors and inotropes should be at hand, and they should be induced with a cardiostable anaesthetic, with classically ketamine. A TOE can be helpful to optimise fluid. However, this is not essential. It's important to optimise lung ventilation and use low PEEP settings to enhance venous return. The anaesthetic goals for these patients include: optimise circulating volume, avoid bradycardia, maintain sinus rhythm, maintain cardiac contractility, and maintain a high SVR.